My session is primarily focused on our deep vein protocols, our algorithms, and the evidence of our approach to that. And so, with that being said, the first question is, how did we get to this point? How did we get to this point? What does that mean? Well, why are we even talking about deep vein disease today? Well, many of you most likely have encountered certain scenarios in your care. And I'd love to go over a few scenarios that I think that, again, we all can kind of share in. How about this patient that comes to you, lower extremity symptoms? Doc, I got heaviness, I got tiredness, I got swelling. I read that poster in the exam room while I was waiting for you, and gosh, I have every single one of those features. You say, okay, all right, well, let's get this vein study done. I think you're in the right place. I feel very confident. I feel fairly confident that we can help you. And the ultrasound tech comes back and comes to you and says, Doc, you know what? I really didn't find much. And you say to them, really? First thing I would do is check the equipment, make sure everything's functioning okay. You know, is everything being done accordingly? Are they following our protocols? Are we getting the right views? Maybe repeat the scan. I would ask the vascular tech oftentimes and say, hey, let's get somebody else's eye on this. Just, sometimes to the vascular tech's chagrin, he or she would not appreciate that. But again, nothing personal. We'd say, let's just get another eye on this. Let's see if there's somebody else who sees something different. And oftentimes, more than 95% of the times, they did not. It was the same exact findings. What about patients that came to you similarly with advanced SEEP and VCSS scores? They're saying all the right things, you're looking at their legs, you're like, oh my gosh, look at that hyperpigmentation, you're taking pictures, you're showing it to your colleagues and saying, man, this patient definitely has venous insufficiency. Look at those skin changes. This patient has C4 disease. Same scenario occurs. The tech comes to you and says, Doc, I don't see any actual reflux. I can't find anything that's in that area. Well, what I would do is repeat the above. Check the equipment, ask for another study. Oftentimes I'll consider a career change because, gosh, what am I doing wrong? Maybe I'm not asking the right questions. Maybe I'm not just getting it. Maybe I just don't understand what the SEEP classification is. What about patients that come to you, they say, Doc, thank you so much for what you've done. Sometimes they don't say thank you so much. Sometimes they say, what did you do to my leg? Because I don't feel any better. Have any of us ever had those patients by raising hands in the room? I know I've had plenty. I'll put 2 hands up, right? So it oftentimes happens to us, and we say, well, that's very interesting. So what do we do? Naturally, as a clinician, we look for other causes. What else is going on here? Could it be a neurogenic cause? Could it be an arterial cause? Is there other things that could be contributing to this patient's symptoms? And oftentimes, unfortunately, I would label the patient as crazy. Oh, they don't know what they're talking about. Get out of here. I did an ablation, the vein is closed, they're telling me that, the symptoms haven't improved? No, get out of here. And we would just kind of label it, right? Not a good thing. How about recanalization of previously treated veins? Anybody here ever have recanalization of previously treated veins? Yes, we all have, and it happens often to us. The key is persistence of symptoms. Again, if a patient comes to you and says, Doc, I feel great, and you do the scan and the vein, some of the vein is recanalizing, obviously you're going to leave it alone because the patient has no symptoms. But oftentimes these patients will have persistent symptoms, and we'll go ahead and do the study and say, oh my gosh, what are we going to do in this scenario? Well, what do we do? I would blame the patient. Oh, they didn't wear the stockings. They weren't following my directions. They must have done something wrong to make that vein open up. And oftentimes blame the technology. Oh, that stinks. Thermal technology, it sucks. Non-thermal technology, it doesn't work, right? No, wrong. But that's how I got to this point. Because we would have these conversations, and our fearless leader, Dr. Sanjeev Buckenhall, would say, Vinny, we have to do better. If we're going to be a national leader, we have to do better. We can't just end here. We can't just tell the patient, go look for other causes. There's got to be something else. And so we spent a lot of time. We spent a lot of time with national experts, international experts. And once we educated ourselves, it started to make a lot of sense. There's an intimate connection between the pelvic venous system and the lower extremities. The next task was, Dr. L said, Vinny, we have to make sure we're doing this right. We are a national leader. We have to make sure we have a protocol. We have to make sure we have a standard definition. Because if we're going to do this amongst 80 plus clinics, we have to make sure everybody's doing it the same way, the right way, the consistent way. And that's where we came up with the protocols. And so I know that this is project as well as I like it to, but these are the actual protocols that we have in our booklets. And the protocols are very simple. We have to define for a patient who has pelvic pain, how long is the pelvic pain been there for? Chronic pelvic pain is defined as greater than 6 months. Lifestyle limiting pelvic pain, right? These patients should have, if they have lower extremity symptoms, a C3 and above. They must have had some evaluation of their superficial venous system. What about patients that have C4 to C6 disease? These patients that come with pelvic symptoms that have C4 to 6 disease, or they have, they have to be evaluated. These are patients that we have to think pelvic if they're having pelvic symptoms. What are the pelvic symptoms defined as? Heaviness, achiness, cramping. What other pelvic symptoms are associated with that? Dyspareunia, right? Pain during sexual intercourse. Why? Increased blood flow to the area. Pain during menses. Why? Estrogen levels go up, smooth muscle relaxation occurs, more blood pools in the venous system. Vulvar varicosities. Many of our patients come from our friendly gynecologists with laparoscopies. And they said, my gynecologist told me that I have these dilated veins. And so all of these features have to be there. Some combination of these features. And if they don't have any combination of these features, if they don't have chronic lifestyle limiting pain, if they don't have these other features, then we must not proceed. The other more important thing here is ruling out non-vascular causes. We have to make sure that gynecological features have been excluded, right? We have to make sure that we are not just treating the small pie. We've got to make sure we take care of the big picture first and rule those things out. Rule out malignancies, rule out other gynecological causes. Many of these patients come with outside studies. Many of these patients have inconclusive studies. But in the eye of abnormal clinical symptoms, clinical features that are classic, we may proceed with invasive evaluation, which we'll talk later about. What about patients that have purely lower extremity symptoms? Again, chronic lifestyle limiting symptoms, greater than 6 months. Patients that have C3 and above disease, okay? C2 and below, we are going to follow those patients. We're not going to do anything overly aggressive. We have to make sure that conservative measures are followed, just like we do in the lower extremities with the superficial system. And we have to rule out other venous causes, right? All makes sense. So once we do all that, and we recommend that the patient goes on for invasive evaluation, and we'll talk again about how we treat these patients, and some of them may get stenting. The first question is, does iliac vein stenting help? Does it work? And we were privileged to meet Dr. Raju, who was at our actual meeting here last year, and he spent some time with us. And when we asked him that question, he said, "Are you kidding me, Vinay? I've made my career out of this. Okay? This is what I do all day, every day. And go read some papers. Read this paper that I published in 2002. 2002, guys. Basically, I'm not going to make you read it, but it was published in the Journal of Vascular Surgery. He looked at 304 limbs in 2002. 304 limbs that had iliac vein stents in the outpatient setting. Okay? Majority of them were C3 and above. And he, following them out at 24 months, found that 4 features improved significantly: pain, swelling, dermatitis, and ulcer healing. He also showed that the stents were effective when utilized in the correct clinical scenarios with low long-term complications, low morbidity, high patency rates. So how high are the patency rates? Well, he went ahead and in 2013, 11 years later, he published another paper, Best Management Options, right? Over 1,500 patients. And he did the same thing, but he looked at morbidity, less than 1%. He looked at patency rates at 3 years. He compared non-thrombotic patients to thrombotic patients. And he said, what's the difference? How do these patients do? Well, the patency rates of non-thrombotic patients were upwards of 90%. Very good patency rates at 3 years. The post-thrombotic patients, greater than 74%. How about relief from pain? Greater than 86%. Relief from swelling, as you can see, more than 66%. But very importantly, venous ulcer healing, 58 to 89%. If we can look a patient in the eye and say, sir or ma'am, I can give you a greater than 58% chance of healing this ulcer, given the symptoms and given the features, I think the patient will go for it, and I think it's very, very reasonable. What about pelvic congestion syndrome? And we talk a lot about pelvic pain. Pelvic congestion syndrome, and we've defined it in our protocol. How well does pelvic congestion syndrome, the treatments and the evaluation work? Well, the first paper that was published in 1993 looked at a woman who's 40 years in age, and they looked at this patient and they did a case report and they said, how well does embolization work? And this patient, described by Dr. Edwards out of Glasgow, was doing great work and publishing, and so this was very, very important. How about coils versus surgery? Because we use a lot of embolization techniques. There's coils, there's chemical, and there's ligation. And so this study looked at surgical ligation versus coils, and they found that these patients did equally well. So embolization works. It's not inferior to open surgical ligation. These are papers that were published between 2002 to 2012, 13. These are all landmark papers that were done that looked at embolization. And basically the bottom line here is that when we look at embolization, many of these papers looked at left and right ovarian vein embolization. And so in our practice, we're doing left ovarian vein ablations first, and then we're bringing these patients back to see how they do. Does treatment of pelvic congestion syndrome make sense? Dr. Kathleen Gibson, who's here today in the room from Seattle, Washington, published this very good paper with Dr. Meisner saying that, guys, at the end of the day, when you look at these patients that come through, they're getting hysterectomies, they're getting all these open surgical procedures, embolization does work and it does help. What about patients that come with pelvic and lower extremity features? Well, I'm not going to brag, but Dr. Pappas has helped us publish landmark papers at the Center for Vascular Medicine in this, showing that if we looked at these patients and if we treat them, we look at them retrospectively in our study, and we find that those patients that had first vein stenting of the venous outflow obstruction treated, and then given symptoms, came back for ovarian vein embolization, did better than those patients that had treatments done simultaneously. And again, we'll be happy to give you these publications. Well, what happens when a patient comes with superficial venous insufficiency and venous outflow obstruction? It is debatable, and Dr. Pappas does a great job for us at the national stage to help us, debate this and get us to where we need to get to. But in our practice, while every patient is treated as a patient and an individual, C3 to C4 patients will have superficial veins treated first. Then pending persistent symptoms will then go on to treat the venous outflow obstruction. So very important to understand that we're not going to go ahead and just start willy-nilly stenting every patient. We're going to see how they do after their venous ablation. But any patient that is C5 and above will be treating concomitantly. And in conclusion, we have come a long ways. I'm very proud of our team. I'm very proud of everybody here today. We certainly have a lot to learn. And more importantly, we have a whole lot to accomplish. And again, I'm very proud to be here and proud to be a part of this esteemed panel. So thank you guys very much. I appreciate your wonderful attention.